The topic of this talk is alcoholic hepatitis. In this session, I'll be talking about the diagnosis and management for this important clinical entity, which can develop in patients who drink significant amounts of alcohol. I have no financial disclosures relating to the topic being discussed in this lecture. There is a wide spectrum of liver diseases which can occur as a result of alcohol consumption. Histologically, the liver may appear normal, as not everyone who consumes alcohol will develop liver disease. Thus, a percentage of patients who drink alcohol will actually have normal livers. However, in patients who develop liver disease, the spectrum can vary from fatty liver to steatohepatitis to cirrhosis. Fatty liver is manifested by the presence of fat in the liver, which is predominantly macrovascular in character. As you can see on this picture, this whitish globule that stands out prominently, this is the fat. This is in contrast to microvesicular fat, which has a hazier appearance, resulting from other kinds of liver disease, such as fatty liver pregnancy or Reye syndrome. Steatohepatitis essentially refers to the combination of fat and inflammation with accompanying evidence of hepatocyte death. A subset of patients with this appearance have severe alcoholic hepatitis, which is the topic of this talk. Fibrosis can be present in both fatty liver and in steatohepatitis, and if there is significant fibrosis, this is called cirrhosis. The likelihood of developing liver disease increases with both the duration and amount of alcohol consumed. Thus, in this study by Lelbach, 319 patients were studied in a German alcoholism clinic. The mean duration of alcohol abuse and mean daily alcohol intake was much higher in patients whose histology showed steatohepatitis or cirrhosis as compared to those with normal fatty liver. Although drinking a significant amount of alcohol is a prerequisite for developing steatohepatitis and alcoholic hepatitis, whether a specific patient will develop alcoholic hepatitis is dependent on multiple factors which are yet undefined. One particular factor which appears important is gender. At any level of alcohol consumption, women have a higher risk of developing alcoholic hepatitis. As you can see in this graph, which represents two different studies, the first two lines closer to the area are women who develop alcoholic liver disease as opposed to men. In both of these studies, you can see that women have to drink a lot less alcohol to develop liver disease, and thus it is not surprising that women in general develop alcoholic hepatitis about 1 decade prior to men. The diagnosis of alcoholic hepatitis is clinical, and I hope that by the end of this talk you will be able to make the diagnosis without having to do a liver biopsy. Alcoholic hepatitis can occur at any age, but typically occur around the age of 30 to 50, with women presenting about 1 decade earlier than men. Men generally don't present until age 40. So to make the diagnosis, you have to look for signs of alcoholism, and be astute about how to ask your patients about their alcohol use. Often, patients will reply that they don't drink even though they stopped a week ago because at the time of your interview they have stopped drinking. Other clues of alcohol abuse might be evidence in the history of multiple traumas, DWI or driving while intoxicated, or a family history of alcohol abuse. Patients may not always be forthright regarding their alcohol use, and therefore it was very important that during the history you ask particular questions. The signs and symptoms of alcoholic hepatitis are somewhat nonspecific. As you can see in this graph, the symptoms of alcoholic hepatitis are most commonly vague symptoms such as weakness and anorexia, which can occur in any form of hepatitis. What is remarkable is that on signs you may see a very large liver, hepatomegaly, which is a very common characteristic of alcoholic hepatitis. In fact, alcoholic liver disease is one of the liver diseases that are characterized by large livers. Jaundice also occurs very early in this disease and often is very severe. These are the patients who come in with a bilirubin of 28 and give a history of it appearing just yesterday. It is as if they did not notice that they were so jaundiced till yesterday. And this, of course, probably fits into the characteristic of alcoholism, being unaware of their personal appearance. Other signs may be evidence of all the signs of portal hypertension, such as splenomegaly, caput medusa, ascites. Patients can also present with hepatorenal syndrome and hepatic encephalopathy. In alcoholic hepatitis, feminization signs are also very common, as alcohol has a direct effect on testicular atrophy, and thus spider angiomas are often seen in this disease. If you don't see spider angiomas, it may bring some question as to whether or not you have the correct diagnosis. The laboratory findings in alcoholic hepatitis are the following. You will see leukocytosis, thrombocytopenia, and anemia. Leukocytosis is very common, as this is an inflammatory disease. However, although it is very common, exclusion of bacterial infection is very critical, since bacterial infections are much more common in this population, and patients can easily die from bacterial infection. Thrombocytopenia is also very common, likely because alcohol may have a direct marrow suppressive effect. Anemia is also very common in this population. Impaired liver function can occur with decreased albumin and increased INR. Decreased albumin is very common as patients with alcoholic hepatitis suffer from alcoholism and often results in nutritional deficiency, which compounds the problem of decreased albumin. Hyperbilirubinemia, as I mentioned before, was also very common and occurs as a very prominent characteristic of alcoholic hepatitis. Bilirubins can rise very high, easily to the double digits. Most characteristically is the increased AST to ALT ratio, which is usually more than 2 to 1 and sometimes more than 3 to 1. The reason for this characteristic ratio of AST to ALT can be demonstrated in this picture. As you can see in this picture of a hepatocyte, there are multiple different areas where the liver enzymes reside. In regards to AST and ALT, you can see that ALT resides in the cytoplasm, as opposed to AST, which resides both in the cytoplasm as in the mitochondria. So, as you can imagine, in a disease such as toxin-induced liver injury or viral hepatitis, where there is massive necrosis and breakage of the cellular membrane, release of cytoplasmic AST and ALT both occur. However, this is not the pathogenesis in alcoholic hepatitis. What happens in alcoholic hepatitis is a prominent display of mitochondrial dysfunction, and thus AST, which is found both in the cytoplasm as mitochondria, are released in a much higher level than ALT. The pattern of transaminase elevations in alcoholic hepatitis, as I mentioned to you before, is very characteristic. However, it's important to note that the AST and ALT don't get to the levels that occur in other diseases. In fact, levels of AST and ALT should not exceed greater than 400. Higher levels are suggestive of other causes, such as viral hepatitis or acetaminophen-induced hepatotoxicity. In this graph, you can see that in the grouping of patients who had acetaminophen-induced hepatitis in alcoholics as opposed to alcoholic hepatitis, that the mean levels are completely different. Alcoholics are predisposed to acetaminophen toxicity. This is because acetaminophen is normally metabolized by going down the glucuronide or sulfate conjugate pathway. However, in the presence of overwhelming acetaminophen, the acetaminophen goes down a toxic pathway, the cytochrome P450 pathway, and it results in the formation of a toxic metabolite, NAPQI, which is a reactive oxygen radical, which depletes glutathione. The vast majority of time, NAPQI is sopped up by the glutathione. However, the reason that alcoholics are predisposed to liver injury is that patients who have alcoholism have elevated levels of cytochrome P450 as a result of chronic alcohol use, and they also have depletion of glutathione due to chronic alcohol abuse. These two parameters make it much more likely for patients with alcoholism to suffer from acetaminophen-induced liver injury, and therefore this combination is something that you should always be looking for, particularly if the transaminase levels are higher than you would anticipate with alcoholic hepatitis alone. Although I mentioned to you before that a biopsy should not be necessary, if you do a biopsy, the biopsy is characterized by, as I mentioned before, fat and inflammation causing steatohepatitis. But another characteristic part of alcoholic hepatitis is the presence of Mallory bodies. Mallory bodies are essentially microtubule conglomerates that occur in the dying hepatocyte. Alcoholic hepatitis is a very severe disease and the prognosis can be quite poor. As you can see here, there are two main prognostic factors that need to be thought of. One is creatinine and the other one is bilirubin. As you can see, as you have rising creatinine, 30-day mortality can be so severe that if your creatinine is greater than 4, you can have an 80% mortality. Similarly, if your bilirubin is greater than 25, you can have a 50% 30-day mortality. If you can imagine, a 30-day mortality of 80% or 50% is actually quite severe, and it's something that you need to keep in mind when you see your patients. One thing that's very interesting is that from a clinical standpoint, one would not have thought that a creatinine of 4 could have such a bad prognosis in disease. In contrast, your bilirubin can reach quite high to get similar levels of mortality, therefore illustrating how bilirubin rises early and high in this disease. An important way to look at prognostic factor is to calculate what we call the modified discriminant function. It is an equation that involves the prothrombin time of the patient minus the prothrombin time of the control multiplied by 4.6 plus the bilirubin. This is a very important equation to calculate because if it is greater than 32, your patient has a greater than 50% chance of dying during that hospitalization. This is also a very important equation to understand so that you can determine who will need steroid therapy. Although the prognosis can be very bad for alcoholic hepatitis, the best part about this disease is that there is a certain component of reversibility. In fact, reversibility of portal hypertension can occur. All the signs and symptoms of portal hypertension, ascites, hepatic encephalopathy, and varices can all reverse, but it may require 6 to 12 months to do so. This is a very important factor, as many doctors feel that if your patients have cirrhosis, they often tell their patients, well, you have end-stage liver disease and there's nothing that can be done. However, it is important to keep in mind that actually some percentage of these patients, if their disease is from alcohol, can actually improve if you stop the alcohol. Again, the problem, however, is that it doesn't occur rapidly. It will require 6 to 12 months, and I have had patients that have gotten better after 2 years of abstinence. This is probably a reflection of the fact that some of the portal hypertension that occurs in alcoholic hepatitis is not due to strict fibrosis, but rather to a dynamic nature. One is caused by the activated stellate cells. Stellate cells are the cells in the liver where, in the face of inflammation, will actually activate. And when they activate, they become like myofibroblasts, stretch out. And there's a certain dynamic nature to these cells. They respond to things such as endothelin, which will make them contract. And therefore, if they're sitting in the sinusoids of the liver and they contract, you can understand why this might cause portal hypertension, and that this is a dynamic nature of portal hypertension in this disease. So what are the treatment for alcoholic hepatitis? Most importantly, abstinence. Other important factors are nutritional support. And the third important factor is corticosteroids. Abstinence is critical. If your patients become abstinent, they can actually improve from their alcoholic hepatitis to the point of normality. I've had patients who come back 2 years later who completely look normal in every single way, including liver synthetic function and even in their liver histology. Certainly, there is a point of no return such that even some patients who remain abstinent will continue to progress to cirrhosis despite having stopped drinking. And therefore, it's important to recognize that if your patient has reached that point of no return, they, even with abstinence, may require a liver transplantation, and that is something to keep in mind. Therefore, careful observation of your patient and continued follow-up is very important. The problem is abstinence is a very difficult thing to achieve in this disease, but is something that should be strongly encouraged. One part of alcoholic hepatitis that may not be well recognized is nutritional therapy. It's important to know that mortality in alcoholic hepatitis correlates with the severity of protein-calorie malnutrition, with a 30-day mortality at 2% with mild malnutrition, while 52% with severe malnutrition. This is very important since patients with alcoholic hepatitis oftentimes have alcoholism, and therefore alcoholism can be very nutritionally depleting, and therefore patients will have a tendency to be malnourished. Second of all, having alcoholic hepatitis makes them weak and anorexic, and oftentimes they will not feel like eating. And therefore, nutritional support during this disease is very important and may require enteral tube feeding. There have also been some studies that show that nutritional support as primary therapy may be potentially important. However, the studies have not been conclusive in this regard. Close attention to nutritional support is recommended. Enteral feeding is preferred as opposed to intravenous feeding, as patients are very prone to infection, and therefore, if at all possible, enteral feeding is recommended. It is recommended that you do not protein restrict these patients if at all possible. There's only a very small percentage of patients who have hepatic encephalopathy due to high protein, and therefore it is important in this population, which are already malnourished, that you only protein restrict patients who absolutely need it. In regards to treatment of alcoholic hepatitis with steroids, it is important to recognize that steroid therapy is only indicated for a subpopulation of patients with alcoholic hepatitis. In the early trials, these were always defined as patients with a discriminant function of greater than 32. For patients who do not have a discriminant function of greater than 32, previous studies have shown that steroids are actually not beneficial in this group of patients and therefore not recommended. Of note, most of the large trials on steroid therapy also excluded patients with other concurrent problems such as viral hepatitis, pancreatitis, etc. And therefore, it's important to recognize that steroids should only be given to a select population of patients with a discriminant function of greater than 32 who do not have other significant comorbidities, in particular infections. For patients with severe alcoholic hepatitis who are given steroid therapy, the trials were done with prednisolone 32 milligrams per day. However, in the United States, people often give prednisone 40 milligrams a day for 4 weeks, followed by 2-week taper. It is very important to taper the prednisone over a very rapid period of time, because infection is a very common cause of mortality in alcoholic hepatitis, and patients should not be tapered off of prednisone over a long period of time. Thus, a rapid taper over 2 weeks is recommended. In regards to predictors of response, it's important to recognize that once you give steroids to patients, that response occurs very rapidly. In fact, Matt Theron et al. Found that if you had no change in bilirubin at 7 days, this was a single factor to determine the non-responder. And those who responded did well, had improvement of liver function during treatment. 6-month survival with early response was 83% versus 23%. In addition, Morris et al. Found that a drop of 25% in bilirubin after 6 to 8 days was associated with good outcome. And therefore, it is important to recognize that once you give patients steroids, you should see a response in anywhere between 6 to 9 days. And if you do not see a response, it may be time to stop the steroids and consider an alternative therapy. A second-line therapy for severe alcoholic hepatitis is pentoxifylline. Pentoxifylline improves short-term survival in alcoholic hepatitis. In this study, they found that in 101 patients were randomized to pentoxifylline or placebo. All had severe alcoholic hepatitis with the discriminant function of greater than 32. Again, in this study, patients were excluded if they had bacterial infection, GI bleed, cardiovascular disease, or pulmonary disease that were significant. As you can see in this graph on the right, in the solid line of patients who were given pentoxifylline versus dotted line of patients given placebo, there was an improvement in short-term survival. In this trial, patients were given 400 milligrams TID or placebo for 28 days. They had actually randomized the patient with a stratification of patients with creatinine greater and less than 2.5, so that equal numbers of patients with good and bad kidney function were stratified both groups. Although the mechanism for pentoxifylline is unknown, it may be that the improvement in survival was actually due to improvement in renal function. Thus, it was very important that the patient had been equally distributed into the two groups. At this point, this is one of the few studies on pentoxifylline, and therefore it is very promising and could potentially be used as a second-line therapy, particularly for if steroids are not possible. It certainly has less side effects than steroids. In regards to other therapies, it is important to note that at this point, we do not feel that anti-TNF therapy is indicated in alcoholic hepatitis. As you can see in the last 4 studies that were done with anti-TNF therapy, there is some question as to whether or not anti-TNF will work. Originally, when we started with a non-randomized study with infliximab 5 milligrams per kilogram for moderate to severe alcoholic hepatitis, it looked like survival was promising. However, once the studies were done in randomized placebo-controlled studies, you can see that the later studies with infliximab and etanercept actually showed worse survival in patients given anti-TNF therapy due to predominantly infections. And therefore, at this time, anti-TNF therapy for alcoholic hepatitis is not indicated. In summary, therapy for alcoholic hepatitis include supportive care, abstinence, attention to nutrition. Steroid therapy should only be given in patients with a discriminant function of greater than 32. You should have a low threshold to work up for bacterial infection, and you can consider switching from steroids to an alternative medication if there is no response by day 7. So the take-home message. Alcoholic hepatitis is a form of liver disease from alcohol with distinct clinical features. It is characterized by significant hyperbilirubinemia, an AST-ALT ratio of greater than 2. An important prognostic score to calculate is the discriminant function. Finally, steroid therapy has been found to be beneficial in a subgroup of patients with severe alcoholic hepatitis as defined by a discriminant function of greater than 32. However, other treatments include abstinence, nutritional support, and general supportive care. Thank you.